Now, for the official inauguration of our event, it's our pleasure to have with us Dr. Rajeev Jayadevan, Gastroenterologist at Sunrise Hospital, Ernakulam. A writer, orator, and social activist, Dr. Rajeev Jayadevan is an expert in the field of gastroenterology and is credited with the establishment of gastroenterology department at the Sunrise Hospital, Ernakulam. He was also the former president of IMA. In a career spanning for over more than 23 years, he has several national and international publications to his name and an extensive international experience of performing more than 19,000 endoscopies. Now, on behalf of Government Law College, Ernakulam, I welcome Dr. Rajeev Jayadevan for the inaugural address.
Good morning to all. As always, it's an honor to stand here in Government Law College, Ernakulam. Been invited by Dr. Bindumol and her fraternity on multiple topics. I recall, I think it was motor vehicle accidents and then trauma care. Those were some of the topics we took over the years. So many of you are familiar to me and others are not. So first, I acknowledge all the senior faculty here. I'm not naming each one of them. And also the organizers and the wonderful people who are seated here listening to this program. One of the things I brought back from my stint outside of India is that the world is driven more by perception than by facts. That is one of the most profound realizations I had, because as a man of science, I was always going with facts written in textbooks and medical journals, lectures and so on. But my experience in other countries and later in India showed me that actually it is society is driven more by what people believe or what people choose to believe. So we have an elite gathering here of the most intellectual people. We are the cream of society seated here. And I'll invoke what I often call the seminar paradox. The seminar paradox is the people inside the seminar room are always the people who need the seminar the least. In other words, the people who need the seminar are always outside the seminar room. So I would request each one of you to take this responsibility to take these facts that we discuss here and pass them on to people. And as I train doctors, I tell them, please talk with people who disagree with you. Talk with people who have an opposing standpoint. So I'll request you also to have the courage to talk with people who might not agree with you, especially on the facts that are discussed here. So with that, I will take you through the science of organ transplantation. Again, I'm aware that all of you know the facts, but I'm also a trainer of communication skills for doctors. So there are certain things that we can actually explain better with using certain examples and terms. So you can consider this like a training of trainers. You can use these simple terms to explain to the public. The first thing to understand is that the general awareness about the process of transplantation is close to zero, really, because thinking takes energy. The brain has to spend energy currency to think, actively think. So, for example, I've written on information overload. For example, in a quote, the decisions taken early in the morning may not be might be better than the decisions taken closer to lunchtime because the fatigue comes in. Likewise, when we talk about the mind, we need to absorb some information and pass it on to other people without dilution of the effect. So I'll talk about how a transplant is done. Broadly, there are two variations. One is cadaveric and the other is living donor. Again, I'm aware that you know the difference, but I'm explaining it here so that you can use these to explain to other people. Living donor, for the plain, I'm talking lay people, equal to mafia. Because the lay people use the word mafia a lot, which is a terrible term that's associated with drugs and human trafficking, prostitution, etc. But living donor is the one subject in medicine that needs to be cleaned. Again, I'm not blaming the medical fraternity or the legal fraternity here. I'm talking about the unscrupulous, ugly underbelly of the society that make plenty of money across the world using this living donor trade. And the previous speakers alluded to that. Coaxing an illiterate person in a bad situation, a bad financial situation, luring them with money, or asking them to donate their organs, creating fake documentation as they are a relative, and so on. So that is one area that all of us have to fight against. That is, it's okay for a living relative to donate an organ, I understand that. But if a non-relative is donating, the process must be absolutely transparent and foolproof. Make sure that this person is not a victim. The person may not be a 100% victim. The person might be a beneficiary of sorts. So that's where things get a little fuzzy. What if I want money? What if I want to donate my organ? What if I don't donate my organ, my family will starve? So those are ethical questions that will come up. But again, we need to stick with the law here. What is right is you cannot donate your organ in exchange of money. I hope that is correct. I think that's a fundamental principle that everybody needs to understand. So principle number one, living donor is commonly, or at least it is known to be associated with the mafia. So that's first fact. Second, it's illegal. I think people need to understand that. It's illegal to accept money in exchange of an organ. And that's, again, a concept that's very difficult to get into people's heads. That's concept number two. Now I'll come to cadaveric donor. So cadaver is in anatomy, the body that's kept on the table, or in the mortuary, the bodies that are kept wrapped up. That's the image that comes to mind when we hear the word cadaver. So when a regular person who's not a scholar like yourself hears the word cadaver, the imagery that comes to their mind is somebody prowling into the mortuary in the middle of the night and stealing organs from a dead body. You'd be surprised how many people believe that story. You'd be surprised. So we must explain to people that a cadaveric donation comes from a person who's brain dead, but whose organs are kept alive by artificial means. It's very difficult to explain this concept to somebody who does not understand the basics of biology. It is. Trust me. Off the record, I'll say even not all medical professionals understand the difference. With all due respect to my fraternity. They don't. So imagine if all medical professionals don't understand the difference. Imagine the lay people. So I'll repeat that. Cadaveric donation, or deceased donor is the correct word for it, is for people whose organs are kept in good condition, but their brain is no more. It is irreversibly damaged. Now that is where the concept of brain death comes in. So we've all discussed, I'm sure you know more about the law about brain death than I do, but again, for the purpose of educating the public, I'll say this. Brain has two stories, that is upper story and lower story. The upper story is what we are all using now. We are using the cerebral cortex to think, analyze, judge, assess, look at facts, and come to a conclusion. The stalk of it, you might think of it like a cauliflower. The cauliflower has a stem, right? That stem is the brain stem, which controls all these other functions like our breathing, our heart rate, blood pressure, temperature, etc. That has no higher functions. If I hang myself, theoretically, I'm just using a medical term. Suppose I hang myself, as the noose tightens on my neck, oxygen supply to my brain stops, right? The first part to die is the upper story. So the upper story is dead. If oxygen is not restored, after some time the lower story also dies. What if somebody cuts my rope when only the upper story is dead? My brainstem will remain alive. Is that correct? So I'll be breathing on my own. My heart will be beating on itself, but the brainstem is alive. That is not brain death. Brain death when both the upper and the lower story are dead, and the rest of the body is kept alive only because of machines. I'll give you an example. Say 60 years ago, or let's say 70 years ago, when there were no ventilators, there was no confusion about death. A person died when they stopped breathing. What happens when you stop breathing? You don't get oxygen and everything dies, no confusion. But now we have machines that actually supply oxygen inside the body by artificial means, even if you're not breathing. And that is where the confusion comes. When the rest of the brain is dead, if you supply oxygen to the blood and you keep the respiratory mechanism, that's the chest expanding and contracting, and with IV fluids and other medicines, you can keep the oxygen levels up, the heart will continue to beat, and the organs will remain alive. But that is a dead individual with an intact organ. So those are the people from whom organs are harvested. The word harvested is a little off, but that's used because I don't think there's a better word for that. But harvest is more used in agriculture, and it's got that positive connotation. Harvesting of organs is done from such an individual. That person is dead. So again, when you explain to lay people, you can say, before ventilators arrived, there was no confusion about death. But now the law requires a definition about death, and we all know about the legal definition of death, right? Of brain death. So that is point number 3, what we need to educate the people. And when I talked about perception, we heard from if you look at the last 1 month of, say, if you look at the social media headlines, you see all sorts of very inflammatory, emotionally charged remarks like "Konnitta avayavam eduthu maati," things like that. So, but the problem is when you make an inflammatory remark, it goes deep into our emotional memory. We tend to remember these better than these facts. What I gave you are boring scientific facts. Those will easily be forgotten. But if I say a doctor killed a patient, then that will enter deep into your memory, and that eventually will drive your decision making. So that's why I said perception can actually drive your decision making. And we are now living in an era where the verdict is passed by people who type on their phone screens and not by people who are authorized to do so. Every day we see verdicts being passed. So everybody has decided, even before the case is actually being called, everybody has decided that, okay, these doctors have killed. So I'm not going to get into the specifics of this Lakeshore case, except to go over a few general things again to make the public understand. There's something called medical decision making, or MDM, medical decision making. It's based on clinical judgment of an individual at a given time by the treating team. So no two patients are in the same situation in two places at all. Every individual, every situation is different. It's like one person might have a bleed in one area, the blood pressure may be low, the limb may be severed, there may be some issues in the family. There are so many problems with each patient. But the medical decision taken at a time is the decision based on what happens at that time around that patient. So when we try to look at a decision that is made at another time, we must remember, we must try to recreate exactly what happened there. But that is where documentation comes in. Sometimes when I teach doctors about communication and others, I tell them, look, you've got to write down exactly what your thoughts were, why some decisions were made. Because if you don't write down, then nobody's going to know why you made that decision. So I understand that there are some doubts about what documentation was made. I have not seen the records of this case, and I'm no expert on that case at all. But medical documentation again is something that, as legal professionals, you must emphasize your doctor colleagues and your healthcare colleagues as well. I hope that they will learn a lesson from, I know it's a harsh word to say, from these cases. Until a problem happens, people do not change their behavior. So I know medical documentation has always not been very good across the world, and it is not practical also. Sometimes doctors work in very constrained settings. The other day, yesterday night, we were talking about a renowned pediatrician. He said he only has 4 minutes to see a patient. He said there are so many people waiting outside. He's so good, patient walks in, he can tell what's wrong. But what if he makes a mistake? What if he makes a mistake? So we, especially in countries like ours, doctors do work in suboptimal conditions. I've worked in the West for 13 years. I have my old patient scheduled for 10 minutes and new patient scheduled half an hour. So I take a full history. I have the luxury of understanding what that patient's problem is fully before I make a decision. I can communicate effectively. But what will a government doctor do in a primary health center where 100 people are waiting with fever? What communication is going to happen there? I don't know. I would go crazy if I was placed in such a sitting. My hats off to some doctors who actually work in those settings. So again, this is not an attempt to justify certain people or otherwise, but we need to take in all these facts. What I give you are all these facts. One, about brain death. Second, about cadaveric donation. What is living donor donation? What could potentially go wrong with it? What is the extortion that could potentially happen with the living donor? And then I'll come to, in my last part of my talk, I'll explain how the deceased donor actually works. Now I explain what that patient looks like, right? The patient has had, commonly it's a head injury. I work in road traffic accidents. I work on the prevention side. Bindumol and I had worked so many years on that. When a person commonly has a severe head injury and death is certain, that is, death is certain, that person becomes a potential organ donor. That's typically how it happens. Now, death needs to be certified by what is the official protocol, and you can see that in an excellent article written in the Indian Journal of Critical Medicine, IJCM. It's beautifully outlined by a professor of anatomy. It's very, very nicely done, and by that process, brain death has to be documented. And that's when I said what was the norm in 2009 might not be the norm now. So I think we need to keep that also into consideration. But brain death has to be certified by protocol. It's black and white. The way it's certified is black and white. Well, I'll tell you one thing. There is something called the apnea test. You know what apnea is, or apnea? Apnea is how it's said in England, I think. Apnea is when you stop breathing. Suppose I stop breathing. I'll explain some physiology to you. Suppose I stop breathing for now voluntarily. In my blood, my oxygen level is dropping. And in my blood, the carbon dioxide level is increasing. Because my lungs are actually exhaust pipes for my carbon dioxide. So if my lungs are not breathing, my lungs are not working, the carbon dioxide produced in my body will build up in my body. Are we clear on that? Okay. Now, if you check my blood, let's say a minute after I hold my breath, my carbon dioxide level will be high. But if I take a breath after that, that carbon dioxide level will drop. So that is the apnea test. If natural breathing does not occur, your carbon dioxide level will continue to rise. And that is documented in a very controlled setting by an expert panel of doctors. I believe 4 doctors are needed for that, and you're aware of that. But you have to document that. Now, therein lies a problem. When you try to document this, you have to shut the ventilator off. Now, that is what I call a Nyaninmel Kali. How do you shut the ventilator off if you're not sure the patient is dead? How do you do that? We'll wait for them. So, back to the question. We are trying to do an apnea test on a patient. You need to make the patient stop breathing with the machine. Right? Patient can only breathe through the machine. So, you shut the machine off. You want to document the carbon dioxide coming up. When you shut the machine off, oxygen level is going to drop. So, how do you know you're not killing the patient? By the process of doing this. So which is why I said it's an extremely complex. It's easy for somebody on WhatsApp to say, idu cheyidilla, adu cheyidilla. There are some barriers for doing the apnea test. You're not supposed to do it, for example, if your oxygen level drops. You have to keep a tube deep inside the windpipe, delivering a lot of oxygen to keep it high, do the test within that time, and then put it back on. So that is a complex situation. And then if the pH level, the acidity level in the blood is abnormal, you can't do the apnea test. You're not supposed to do it. So there are some situations where you can't do the apnea test. So there are situations where organs are lost simply because the apnea test cannot be conducted. That's the Nyaninmel Kali that I mentioned about. So not all patients can actually undergo an apnea test. So there are alternatives for that. I'm not going to go deep into that. It's called digital subtraction angiography. You measure the blood flow into the brain, into the the skull, the cranial cavity. If we can document absence of blood flow into the brain, yes, that is called brain death as well. So again, I just gave you a glimpse of the complexity of these things and how these things are trivialized by people who know absolutely nothing about these processes. So I just looked up some statistics here. I understand that in Kerala, living donor transplantation is slowly increasing. Not dramatically, but I think it in a few years it went up from say kidneys transplants went to from 792 to 1092. It's not a great increase over the years. I would expect that number to really be much more. You know why? Because so many people are waiting, leading miserable lives, going to dialysis every other day, horrible quality of life, and they're waiting and waiting and waiting. So you can wait either for a relative to donate. If you don't have a relative who can donate, what do? You have to wait for the government or the KNOS to allocate an organ to you, and that organ has to come from somebody who's brain dead. And I believe in the last 6 years, if I have my statistics correctly, 27,872 people have died in that manner, of whom 111 have donated organs. So you can see the amount of organs that have gone into the ground without being able to help or improve the quality of life of thousands of people. So that is the tragedy of deceased donor. I know that we do not want even one person to die, and our work on road safety explains that. But but in Kerala, 4,000 people die every year. And that number remained steady except during the pandemic when there was a lockdown. But now the number is 4,000 people, and no matter what we do, that number still remains at that magic 4,000 people, 4,000. With the AI cameras come in, I'm predicting hopefully there'll be a drop, and with this risky behavior will stop. Two-wheelers, some of them drivers would, please kill me. The way they think, please kill me, please kill me. I'm like, if you want to get killed, please don't hit my car. That's my prayer to you. Or please don't hit the poor pedestrian who's walking on the road. So again, humor apart, this is a serious topic. We can't counter perception. We can't counter emotion in society. But that should not discourage us from speaking. So that's what I tell my doctor colleagues to. Say the facts. Say the facts. Even if you think people will disagree with you, say that these are the facts of whatever in any medical situation. Now, you've probably seen my work on vaccine during the pandemic. Many of you have seen my works, read my works. So much perception went on in the pandemic, right? You remember? So much wrong beliefs are still circulating. There are still people who believe that this is some sort of an experiment. The vaccines are experiment and so on. People who believe that, which is why that perception actually drives public belief and actions. There are even doctors who fail to vaccinate themselves and who've suffered consequences as a result of that. Again, because of perception. So perception is a very powerful force, unfortunately negative force in society. So let's fight that together. And I thank everyone for being here and for the organizers for organizing this beautiful event, very well attended and with good talks and with interactions. And I would like to officially state that this program is considered inaugurated. Thank you.